insulin. And the lengthy insulin in our context is called mixture. Is it clear? You give the lengthy insulin when you are less than 250 milligram per deciliters of random blood sugar, the random blood glucose. Is it clear? Now, how do you give now mixture? To give mixture or lengthy insulin, you now give 0.5 to 1 international unit per kilogram. That's how you give mixture, or some people say 0.8 international unit per kilogram. Is equal 0.5 to 0.8 international unit per kilogram, or 0.5 to 1 international unit per kilogram. Now it is in 24 hours, no more in per hour. Is it clear? It means that what? Let's say that somebody has 100 kilogram and I want to use 1 international unit per kilogram to control. It means that in 24 hours, I'm going to give the patient 1.0 international unit times 100. So I'm going to give him 100 international unit of atropine in 24 hours. Is it clear? Now you cannot give him just at one dose. Is it clear? You need to divide it into two. In the morning, you give the patient 2/3, while in the night you give the patient 1/3. Why do you give more in the morning? Give more in the morning because that's the time when the patient is eating, he has food, he's eating, and when he's feeling dizzy, he can eat. Why in the night you give 1/3? Because in that time he's no more eating. So you give 2/3 in the morning. 2/3 of 100, it gives how many? So you give 2/3 of 100 in the morning. Is it clear? And in the night you give 1/3 of 100 in the night. Is it clear? So that's how you can manage the patient with using a mixture. Is it clear? Now the question is, when do you stop? When do you stop insulin? Is it clear? When do you stop insulin? Generally, you can stop insulin when there is no ketone bodies again in urine. When there is no ketone bodies in urine, you can stop insulin. Is it clear? Generally, when there is no ketone bodies in urine, you can stop insulin. Generally, that's that. And when also the patient has gained consciousness and all that. Now, when there is no ketone bodies, you can now go back now to oral hypoglycemics. Is it clear? You go to the oral hypoglycemics, and in the oral hypoglycemics now, you now give either you start by giving, when you give oral hypoglycemics, start by giving the biguanide until the full dose of biguanide. Example of biguanide is metformin. Is it clear? And metformin, you start with 1 tablet per day. Is it clear? And you go to a maximal dose of 2000 grams per day. 1 tablet has 500 milligrams. The maximal is 2000 grams per day. Is it clear? If it fails to control the blood glucose level, you now add sulfonylurea, which is the second line. Sulfonylurea. Is it clear? An example of sulfonylurea is glibenclamide. Is it clear? So you also give glibenclamide to its full dose. Is it clear? If you give glibenclamide and if you give sulfonylurea and biguanide to their full dose, but it does not control diabetes, now you go now to insulin back. Is it clear? And the insulin you give is a mixture, is a lengthy insulin. Is it clear? So generally that's how you control for the glycemia. And one thing again is that every time that you are at the level of less than or equals 250 milligrams, after giving mixture, you change the fluid of the patient and then replace glucose or dextrose 5%. Is it clear? Place glucose or dextrose 5% every time that you are at less than 250 milligrams per deciliter and mixture. Is it clear? So that is for the management of the disease. Is it clear? Now we continue now with the next goal of management, which was potassium ion control. Potassium ion control. Is it clear? When you control the potassium ion level, so after control the potassium ion level, you need to know that what? So you need to normally control potassium level every hour. Is it clear? Every per hour you need to control the potassium ion level. Why? Because potassium ion the patient can have hypokalemia, and there are two reasons why the patient has hypokalemia. The first reason why the patient has hypokalemia is dilutional. Is it clear? Dilutional, because you are giving much fluid to the patient. That's why the patient has hypokalemia. And then the second reason why the patient has hypokalemia is via redistribution. Is it clear? That's the second reason why you can have hypokalemia. It is via redistribution. When you are redistribute, and redistribution is because what insulin, for insulin to cause glucose to enter the cell, for insulin to cause glucose to enter the cell, you need to know that what for insulin to cause glucose to enter the cell is going to push potassium ion into the cells. Also, it's going to move with potassium ion into the cells, and when it push potassium ion inside the cells, it's going to cause reduced potassium ion in blood, resulting to hypokalemia. So those are the two major reasons why you have hypokalemia. Now, it is when the patient has hypokalemia which is less than 3.0 milliequivalent per liters, that is a problem. So when the hypokalemia is less than 3 milliequivalent per liter, that's a problem. Is it clear? And now you need to recompensate the patient. Generally, you can just give 1 ampoule of potassium ion, which is made up of 13 milliequivalent per liter. Is made up of 13 milliequivalent of potassium in that 1 ampoule. Is it clear? You give that 1 ampoule of potassium ion inside the patient. Is it clear? And generally, you need to know that what 1 ampoule of potassium can increase the potassium ion level by 0.2. Is it clear? 0.2 to 0.3. 1 ampoule of potassium. So if a patient has 3, you give 1 ampoule. Is it clear? So that you can go to 3.2. Is it clear? If the patient is already because it can increase by 0.2 to 0.3 milliequivalent. Now the second patient, if the patient is between 2.5 to 3.0, is it clear? You can now give 2 ampoules, because in 2 ampoules now you can increase the patient by 0.3 to 3. Is it clear? Because your limit, at least the limit that you want to attain, is 3. But if the patient now is less than is between 2.0 to 2.5, you now give instead so here you give 1 ampoule, here you give 2 ampoules when you are 2.5 to 3.0, and now when you are